There was one other question in the chat that was referring to squamous cell carcinomas, asking if biomarker testing should be done on patients that have squamous cell lung cancer.
Yes, so I think traditionally, obviously, we've thought of these genetic alterations occur more commonly in non-squamous adenocarcinoma, subset of non-small cell lung cancer, which is obviously true. But I think increasingly, even in high smoking population, we are able to identify certain alterations to which we may have targeted therapies. I think if you look at the NCCN guidelines, I don't think they actually differentiate between non-squamous and squamous in terms of testing paradigms. So even though it's probably going to be less frequent for us to find, and I think in a particular situation where we have a high smoking population where we're not able to get tissue or ctDNA to identify for these biomarkers in those sort of special situations, it's okay to go ahead with treatment if we are able to identify other biomarkers with PD-L1. But I think in most cases, I would say, regardless of squamous or non-squamous, I think biomarker testing will be very helpful and indicated.
And I'll add too that I think smoking status does matter here as well. Now we know that patients who have never smoked who get squamous lung cancer, that's a very rare population. But we reported on some data looking at the CARIS Alliance. We reported on some data at ESMO that showed in never smokers, there is actually an increased enrichment for some of these alterations like EGFR and MET in squamous lung cancer as well. So I would agree with Dr. Desai. I would do genomic profiling on all patients regardless of histology, but certain factors like smoking status might kind of affect the pretest probability of seeing one of these driver alterations.